the medial and lateral thigh with one hand. Let's do the right leg. So put your thumb on the medial hamstring, put your fingers on biceps where you think biceps is. Don't squeeze it, because what we're looking for here is just to feel for activation, okay? Now, athlete, shift your weight to the right leg, and then back to the midline. And you don't have to lift your foot yet, just shift. Shift your weight, and then back to the midline. So, therapist, trainer, can you feel the activation of medial and lateral hamstring? Can you feel the muscle contract into your hand? Yes?
Yeah.
And do you feel both of them coming on, or is one coming on more than the other? That was biceps is coming on more. John's doing this beautifully. Both his medial and lateral hamstring are coming on. And so there you've got the biceps more than the medial side. That's a problem, right? That's a dyssynergy. Anybody else? What have you got back there?
Medial's coming on more.
Medial's coming on more than the lateral. So that's not fitting with Barb's research, is it? Remember, she didn't measure the medial group. And that's what you find. In some people, the biceps comes on before the semi-min and semi-ten. In others, semi-min and semi-ten comes on before biceps. What do we think should happen? They should both come on. They should both come on. Okay? So already you've picked up. We got a problem, Houston. Okay? Now this isn't about strengthening his medial hamstring or strengthening his lateral. It's not about strength. It's about how the brain is saying to the thigh, I need these muscles to come on. Right? It's just playing with the wrong operating system. Now, with your other hand, go feel glute max. Just put your hand on the low butt. Not up on the iliac crest, you'll be on the glute. Knee, come down onto this meaty part of the bump. Okay? Now, again, don't squeeze. Just let your hand be there. And athletes, just squeeze your butt cheeks and relax. Squeeze your butt cheeks and relax. Okay, so you know what a glute contraction feels like now? All right, relax your bum, relax your leg, shift your weight onto the right leg. There goes glute, there goes hamstring. Shift your weight on, there goes glute, there goes hamstring. Now, it's not like a big butt squeeze, is it? It's not, it's more subtle than that. Okay, slowly shift again, John. There goes his glute. Almost immediately, as soon as he shifts his weight onto the right leg, his glute comes on, then his biceps and his semi-min come together. This is perfect. This is exactly what should be happening. And now just start to lift your left toe up off the ground. And now we feel more activation, because it's a higher load task. He needs more muscle. All right, so what has your fellow got there?
I'm not feeling great.
Nothing in the glute. So if he just shifts his weight to the right, and you can just balance on your toe if you like. Now take that glute and do this. It shouldn't be soft, mushy mass, right? So shift your weight to the right, John. Okay, lift your left leg up. Right, so there's tone there. He's activating his glute with a really good response. So right away, you know you've got a dyssynergy between the glute and the hamstring. Now, your athlete had medial hamstring and not.
Yes.
And so what happens in his glute?
Glutes activate after hamstring?
Glute are activating after hamstring. And you?
Glutes are activating first.
Sorry?
Glutes are activating first.
Glutes are activating first.
Late.
Late. All right. And so we've got 1, 2, 3. His was good, right?
This was good.
We've got 1, 2, 3 out of however many groups that we've got here are already in trouble, at risk for having some kind of lower extremity injury when the movement is done with speed. All right, because you're using your biceps, you're using your biceps or your medial hamstring to try and stabilize the lower extremity in some way during a simple leg task. So if you decided to run up the grunts ground or just start to do some really fast running drills, your legs are not going to be happy with that. Okay? Simple test. Simple test. Now, what is this integrated systems model? It's not the integrated model of function developed by Andre and I. This is a model that LJ and I have put together. And the clinical puzzle is a reflection tool that we use in the series of courses that we teach, which is more about how you organize your brain around all of the different things that can cause impairments. But the clinical puzzle is also sort of part of the integrated systems model. We're not going to really get into it too much in the next 2 hours. But what it is, it's not about classifying people. We don't really feel that you can subgroup or classify people into groups very easily. And while it's necessary for research, I think clinically, and when we're trying to understand people's problems, what we need is a framework or a way to organize all of the knowledge that we have that come from all our different experiences through life, through work, through courses that we take, And it helps us then to be able to facilitate clinically reasoning your way through the person's puzzle. So it's a model that considers the whole person and total body function in the context of optimal health. And that's what you're trying to do with your athletes. You're trying to maximize their ability to function and perform by having optimal strategies for movement. And the way you do that is about addressing optimal health. So sleep, nutrition, stress, exercise being one small part of it. But it's a whole person approach, isn't it? It's so different than the medical model, which is just about treating disease. Not just about, it's important, about treating disease, but it's not about restoring health. So it's applicable to disability with or without pain. So we can start to now look at performance factors and be able to tell whether things are working well or not, just like the simple little test we just did. There was no pain involved. I didn't ask anybody if they hurt. It was just all more about an assessment based on function. So it is applicable, however, to people with either peripherally or centrally mediated pain, whether it's acute or chronic, and it's really centered around the individual's values and goals. And so one of the key things about this model that's highlighted that makes it different from others is that is this thing that we call meaningful assessment. It's about more than pain. Relief of pain doesn't guarantee full return to function, and I'll remind you again of the Orchard and Best study, where 30% of these injuries recur 12% in the first week. So just getting rid of pain isn't enough. Relief of pain doesn't guarantee that they're going to perform as well as they used to, and what has meaning often goes beyond pain. So often an athlete will say, I don't trust my leg. I don't trust that I can jump up, that I can land on it, that I can land and then spin and twist. I want to feel agility. I want to be fast again. I want to be that player on the pitch where the other people are afraid when I have the ball, right? There's that whole sense of confidence in the body. It has absolutely nothing to do with pain. So what do we mean by meaningful assessment? Every athlete's experience through the whole tapestry of their life from whenever they started to play soccer is unique, and even if their pain location is the same, the number of things that they are accommodating for, whether it's in the cranium, their upper body, a shoulder injury, a foot injury, it'll all be different because there's none of the two of us, it's the same. And therefore each assessment, even though the location of the pain in the leg may be the same, is going to have different findings. And so you have to have a library of different clinical tests, I'm going to introduce you to 4, that will help you to determine where the primary problem or the primary driver is, okay? So it requires that we use clinical reasoning on the fly, to use the right tests at the right time, and again, this meaningful treatment means that your treatment program is going to be specific to the individual and that there's no recipes. We don't have a protocol. There isn't a protocol or a recipe for it. If you tear your hamstring, this is what you have to do to get better, okay? Because given the same painful impairment, look at these guys. Look at how they squat. They're all squatting differently. Yeah? Position of their feet is different. And maybe it's just for the camera. Maybe that's not what they do. But if we ask these guys to perform their best squat, and this is what you got, then you would be doing way different things for all of these guys. Okay? So given the same impairment, no two individuals have the same experience. Not only because of the physical natures of their body and the injuries they compensate for, but how they manifest their pain and illness is shaped in part by who they are. Their emotional makeup, their psychological makeup, their social makeup, all of that is reflected in what they think and how they feel about themselves, the place in the team, the impact of the injury, etc., etc. Okay? So clinically, how we translate this is that to understand the person with this pain or disability begins by hearing their story and learning what has meaning for them. Now, from the story, which actually gets, the key features get put into the center of the puzzle, we can then choose this thing we call the meaningful task. So meaningful tasks are things that are painful or aggravating. So for example, if we look at this fellow here, is he still with the team, Rick?
Yes.
Yay! Because I got it on the video later. Cut. So, lots of things that could go wrong in that moment, right? And just in the position that he's in, he's at pretty high risk. But what I really see is this shearing through his chest and the inability to flex in that hip. And I'm making this up, right? He didn't say this, I'm making this up. Suppose he says, my thigh hurts when I kick with my right leg and twist my trunk at the same time. So if he comes in and he says to you, trainer, I got a problem with my leg. I can do this, no problem. But I can't do that or I can't do that. The moment I twist my chest and move my leg at the same time, I get this pulling feeling down my leg. So it's not just moving my leg, there's something that's going on in my whole body, okay? So when you get a complicated task like that, so it's not just about doing a hamstring stretch, because his hamstring stretch is good. It's when he links the sling all the way up that something's going wrong. How do I assess that? So that would be his meaningful task. Or maybe you have a player who's saying that they're not as agile or as fast as they used to be. You go, okay, well, let's do some drills, let's have a look and sort of see if I can see what's going on. Too difficult. It's moving so fast and in such a different way that lots of times you can't appreciate the interoception or what he's feeling in the body. It just doesn't feel right. And I'm sure you get that a lot. That would be his meaningful task. Tasks where they experience this not feeling right, either about trust or speed or whatever. Reported to create respiratory symptoms. I get short of breath. I'm not getting into the flow. Ever since my injury, I just don't feel that I can stay, I can breathe as well as I breathed before. So all of these things would then form the basis of what you choose to then assess, okay? So from this meaningful task, we then choose screening tasks, and then we analyze how they're doing them. So let's say hypothetically, this fellow here, let's say he had said to you, when I push off my left leg, ever since, say he tore his left hamstring, you rehabbed him, he's now back, and he says to you, when I push off and I go to sprint this way, with my left leg, I just don't feel like I have the same power as when I go this way. There's something that's not quite right. The first thing you would do is that you would then break that task down into 3 tests that you then look at. In order to do this, he has to be able to stand on one leg and lift the other. Okay? That's a component part of it. Now obviously he's not in the same position, but that would be the first component part of it to look at. He also has to be able to rotate his chest to the right. So doing a trunk rotation screen, okay, we're going to do both of these. Doing a trunk rotation screen would be another key component test that you look at. Because remember, we're trying to determine the driver. Has he lost power in his leg because he can't twist his thorax? Has he lost power in his leg because he can't stabilize his pelvis? Or has he lost power in his leg because the biceps femoris connects through the fibula to the perineal? And I'm sure he's probably had an ankle sprain in the past. Most of these guys do, right? So if he's had something coming up with his foot that's changed the tension in the perineal group, which is then stopping the fibula from moving, which is then sending the force up into the fibula, or up into the biceps to the pelvis, we could have a foot-driven thing coming up. So it probably, because this is a whole body task, it'd be great to pick a screening task that looked at knee alignment and looked at foot biomechanics in the push-off things, okay? Now, we never usually choose more than 3 to put on the outer ring of the circle. Otherwise, you just get way too much information. You get overwhelmed with information in terms of where to go. You're just trying to find what is it that is driving this biceps to work too hard, or this semi-men, semi-10 to work too hard. So for each one of these tasks, you would then identify things that are going wrong. So when you stand on your leg, that SI joint's not supposed to give way. The dining room table is supposed to stay still. The femoral head shouldn't shift forward. Your rings shouldn't, in your thorax, shouldn't shift all over the place. So we identify how many things are going wrong in that task. And then what you do is, and we call that failed load transfer. They're failing to transfer load in a good way, which could mean that they're not lining up properly, they've got non-optimal biomechanics, they're not controlling things, depending on whatever it is they're supposed to do. And then to determine the driver, where's the best way to make the best intervention, we do a couple of things. We look at timing. Which one gives way first? Which one gives way first? Does the pelvis give way and then the hip go forward? Does the hip go forward and then the pelvis give way? If the hip shifts and then the SI joint gives way, there's something about the hip that's driving the pelvis. If when you stand on your leg, you lead the movement by shifting your thorax first to get your weight over your leg, and then your hip goes forward and your SI joint unlocks and your knee goes into valgus. That's a thorax-driven problem. It's the first one that went wrong first. So if that's what happened, what you could then do is then control the thorax, so you could get your hands on the chest and say, just stay long, stay tall, don't let your chest lead the movement, take your weight onto your foot, pretend this is like a box, just take your weight over. And if you control movement here, and then they shift their weight, and the hip stays centered and the SI joint doesn't unlock, you know this is the driver. That what they're doing between here and here is more important. So the whole system's going wrong from here first, and then it gives way. all right? So we look for the timing, what gives way first, and then we look for the impact of a correction of one on the other, okay? So I'll show you some clinical examples of this, but first I want to talk a bit about what evidence we have to define a pelvis that's giving way under load, okay? And I'll let you read some of this stuff on the slide. I'm much more interested in you learning the skills of doing this, so I'm not going to belabor the science. But so many surgeons now still say and are trained that the sacroiliac joint doesn't move. And if you are running into that kind of scenario where some physicians or doctors are saying, look, the SI joint doesn't move, I'm not sure why you're worrying about it, the evidence is very old now, so you just need to tell them to get current. Okay? So Jacob and Kissling did this study in '95 where they put Kirschner wires into the innominate. They did a whole bunch of different things and measured how much in a fairly wide age range of people, what happens in the sacroiliac joint. And to cut to the chase, there's a small amount of movement that happens. Ben Sturson also did some studies where he put tantalum balls into the innominate and the sacrum. And this was done not in healthy, non-painful subjects, but this second study was done in women with pelvic girdle pain, women who were sent to him for consideration for surgical fusion. And the reason I put this in here is that there was no statistical differences found between the symptomatic and the asymptomatic pelvises in terms of range of motion. So pain doesn't necessarily make the joint move more. Pain doesn't necessarily make the joint move less. There's no association between pain and mobility anywhere in the body. So although we may see movement varying between sides, we can't predict whether pelvic girdle pain is going to give you more or less movement. Some of them brace and tighten up with their muscles, and some of them get inhibited and let go, okay? Barb Hungerford, again, the same gal that did the surface EMG studies, used a 6-camera motion analysis system to determine many things about the pelvis, but one of the things was about movement. And consistently what she found in the pain-free subjects is that when you stand on one leg and lift the other leg, that innominate should posteriorly rotate a small amount. So there should be a little bit of give in the pelvis when you do this. And that the movement, although varied between subjects, there's a different amount between subjects, the movement was symmetric. So this is the same as asking someone to bend one elbow and bend the other. And where my elbows may bend a different amount than John's, my elbows should be symmetric. So same with the SI joint. Some people have a lot of movement, and some people have a little bit. So this gal Jill was on the Canadian triathlete team a number of years ago, and this is what this test looks like. So one hand is palpating the ilium, the other hand is on the sacrum, and you can see there's an asymmetry here. There's a difference in the quality, there's a difference in the quantity of movement between sides. Now it's a small degree of movement, 4 to 6 degrees, it's not a lot, big bones, and there's a sense of that the PSIS should actually descend or come down relative to the sacrum. And in her, look where her thorax goes. In her, you can see that there's a difference. So her main complaint was left upper hamstring tension and a loss of balance when standing on her right leg. And when you watch how she stands on her right leg, when we get there, she actually shifts her thorax off to the left before she stands on her right leg. Pretty hard to stand on your right leg when your thorax is over there. All right? So if you leave the thorax behind and try to stand on your leg, it's pretty difficult to do. So looking at pelvic control, which is the test that we're going to do, I want to teach you how to feel the dining room table that's giving way. All right? How do we know we got a buckling SI joint? But so this is the evidence that backs it up. What should happen when you stand on your leg? Nothing. When you stand on your leg, the pelvis should move over the foot and should stay intact. There shouldn't be any giving way at the SI joint. Okay? She's done an intertester reliability study with good results when the bar was set at it's either good or it's not. So it's giving way or it's not, which makes sense in the stability research as well. So this is what it looks like. So this is Jill again. She stands on her left leg, which is the side of her hamstring pain and tension, and she stays pretty good, but watch the right side. So she shifts her weight right there. So my right hand, right at the beginning of the test, and if you watch my fingers in the front, so the fingers in the front are going down, so that innominate is anteriorly rotating relative to the sacrum, and it shouldn't be doing that, okay? It should stay relatively posteriorly rotated. So here we go again. All right? That's a positive test. Okay, so you should have a small but variable amount of movement from side to side, and on the weight-bearing side, this is the test we're going to do. The innominate should remain posteriorly rotated. If it doesn't, in other words, you shouldn't feel anything happen at all, it's giving way. There is a problem. Now, it doesn't mean the pelvis is the driver. This is just picking up failed load transfer within the pelvis. It's giving way, okay? All right, so here we go. Let's have the lights on again. And find your partner. Come on back up to standing. Now, for those of you who are working with someone, actually, let's switch it around and let's. I'm going to use you. If you were the, can I call you patient? If you were the patient last time, be the therapist this time, and then we'll have some time to switch it up, right? Okay. So let's go back to test number 1 and palpate the medial lateral hamstring. Palpate the glute. Shift your weight to the right. Feel for the sequencing of timing. So just with one hand, focus on biceps and semi-mem first. See if there's synergy there. And then palpate the glute. And see if there's synergy there. Switch to the other side. Feel medial lateral hamstring. Shift your weight to the left. Timing between the hamstrings and the glute. All right, now for the next test, you're going to pick the side that has the apparent dyssynergy, where there seems to be some problems, okay? So if one side's working well, that'll be a boring side to look at. Well, it'll be a side where you can actually start to tell good things are happening. But pick the side where there seems to be some dyssynergy, okay? Now, what you're going to do is with one hand, it doesn't have to be on the PSIS. We can't reliably agree where it is anyway. Put your hand on the innominate. Now, if you want to come around and curl your fingers so that it's right on the front of the pelvis, so that your fingers are actually on the ASIS, that's fine too. But I want you to have as much of your hand on the pelvis as you can. If you stroke your hand, if you just feel where your hand is the most sensitive, you'll feel that it's most sensitive in the palm, right? So you really want to be sure that you've got the palm of your hand on the innominate and keep it light. Patient, if you feel like you're being pushed over, they're reaching for the bone. Let the movement of the bone come to your hand. Be light. Now with your other hand, you're going to be on somewhere on the midline of the sacrum is a good place to start. So in the spinous processes. So go find the bone, the spinous median sacral crest here. And you can either use sort of 3 fingers in the midline, or you can put your thumb there. So one hand on the innominate, one hand on the sacrum. And now patients, shift your weight to right or left, whatever side that they're feeling on, and then come back. Shift your weight to the right, pick your left foot up off the ground. And back down. Now don't worry about any glute activation or TFL or anything else. That's all going to be happening under your hands. What you have to feel for is whether or not there is any giving way. Now, the innominate, what Bart found is that the innominate in the track athletes, it tended to anteriorly rotate. Because most track athletes have tight hip flexors, right? Quads, rec fem, psoas, they have tightness in here. So it made sense that she'd feel the anterior rotation. But lots of times what we feel in people with pelvic floor impairments is they actually internally rotate. And other people, they actually externally rotate. So anything other than staying neutral is a problem. And it's just a reflection of which muscles around the pelvis are not working well. All right? So has anybody got one that they think is giving way or that's positive? Yeah? No? Not sure? Hands up.
Probably.
Okay, shift your weight to the right and lift your left leg up. Solid as a rock. No problem. Stand on your right leg. That one's giving way. That one's giving way. Okay, so you stay up there, Jake. Okay. And one to standing. Stand on your right leg. And back down. Stand on your right leg. HT, no, it's good, but your SI joint's giving way. Stand on your right leg. And we have the dyssynergy on the right side, yeah? And back to midline with it. And stand on your right leg. His SI joint's okay. Stand on the left leg. left side's giving way. Left side's giving way. So up at the front, there's 3. Yep, step in front. Anybody else? Did you have the decision? Right.
Yeah.
What's your name?
Marshall.
Marshall. Marshall. Stand on your right leg. And you're up there. Okay, so there's 4. All right, so I'm not going to tell you which one it was. Do you remember which one it was that I felt? You individually? Do you remember, Marshall?
I don't. What was your question?
Am I going too fast? Stand on your left leg. And back down. Stand on your right
This
side.
is my right side.
Exactly. His left side's normal. His right side's giving way. Okay, come feel that, you guys. Stand on your right side. Stand on your left side. His right side's normal. His left side is giving way.
Which way?
Okay, here's some more. You can know when you can feel.
We're gonna go left.
Stand on your right side. And back down. And wow. Relax your bum.
I'm trying to, it's
And
relaxed.
Yes, here's and stand on your right leg.
You got some kind of
And back down. Stand on the left leg. And back down. Okay, so left side giving way.
I'm
Huge
having
bicep.
hamstring pain right now, actually.
You're having hamstring pain right now, yeah, because your femurs are trying to come out, you're into a ligament. Okay, left side giving way. Okay, and Jake, I think it was your right side, right? Stand on your right leg. Yep, and down, stand on your left leg. Yep, right side, okay. And a right one, okay, so just go up and down. And don't try to overthink this. So if you're trying to look for something, notice I haven't lifted shirts up, I haven't got you naked or anything. You can do this on the pitch, you can do this anywhere, in an airport, anywhere. You can feel it through clothing. And you're feeling, it's a small movement. So what I encourage you to do is close your eyes. Close your eyes, get the palm of your hand on the pelvis. And the movement occurs, when it's a significant problem, the movement will occur on the weight shift. If the movement is, if the giving way is starting to occur when they're in a single leg squat and they're going low, 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 and they got their arms out like this, well, it's probably something else that's driving the pelvis than a pelvic problem. When it's a pelvic problem, it will give way fairly early in the movement. If they're starting and it's already given way, and then they just do this and you repeat the test, you'll miss it. Right? So you have to bring them back and then step on the leg again. It's like unloading the dining room table and then loading again. And you're feeling for this little getting away. Okay? Eyes closed is way better because your brain likes to default to what it can see. And right now you're just seeing t-shirt and shorts. Right? So you're going to image and just imagine that SI joint underneath it. And it's a very small amount. You got it, Marshall? Yeah. Cool. So feel some more. Switch it up. We've got some time, guys. What do I mean by giving way when I say giving way? So we have a number of mechanisms that hold the pelvis, hold the pelvic ring intact, right? So we've got some strong ligaments in here. We've got this area totally filled with multifidus and fascia over the top like that. We've got transversus and the internal oblique like this, okay? So it's complicated. And we have the pelvic floor in the bottom, so it's complicated. So what holds the circle intact is all of those things. If anything is going wrong within this circle, what will happen is that the SI joint will be poorly controlled, and what you'll feel is this very small that's giving way. So you'll feel movement. You shouldn't have movement. When you're going to go into either a squat or one-leg stand, this SI joint shouldn't move. It should move in an open chain, right? So it should move like this. So as we're walking and running, there is a small amount of movement that occurs, but never when the SI joint's loaded. So at the moment of heel strike, we get to here, when the bicep starts to contract as it should and your core is contracting, that SI joint's posteriorly rotated at the moment of impact so that shock absorption is through the foot, the knee, the thorax. The thorax is your spring, okay? This is how the thorax should look. Thorax is like this, with all the rings moving. But the pelvis is the solid ring underneath it that, yes, needs to be able to turn, but then needs to be able to be supported and held together. So when it's not, it has a buckle where it gives way, where it moves when it shouldn't. Does that make sense?
Yep. And you can move any direction.
Yeah, the most common one that you're going to find in your group of guys is anterior rotation. Would you think, Rick? Anterior
absolutely.
rotation, more than anything. I see a lot of postpartum women as well with a lot of pelvic floor trauma. They tend to move a lot more into internal rotation. Yoga bunnies, right? White Rock. Lots of yoga bunnies. They can put their legs behind their head. They can do things with their total crazy things with their hips. Their hips are great. And then they deliver a baby and tear out the pelvic floor. And so when that heals in as a problem, the giving way in the pelvis is in a circle. So I see a lot of internal rotation giving way in that group. So it really is subject dependent what you see.
Do you tend to see it unilaterally, or like both sides? In other words, can you just look for, if nothing else, you just feel there's a difference from side to side, or can both sides be pathological?
Both sides can be pathological. It's more common that it is unilateral, particularly in your sport. But you will see it. You can see it bilateral, and it can be a different driver for different sides. So you can have the foot that's affecting the SI joint on one side, or the knee, an old ACL injury, a knee that's not doing what it should do, can affect it here, and it can be the thorax affecting it on the other side, or it could be pelvis. Yeah.
So once again, the baseline normal test was that you should either, I suppose it should be nothing. Everything should feel any sort of movement.
Absolutely.
Then you're.
Absolutely. Okay. So I can do all sorts of funky things with my pelvis. All right, now, what you don't want to do, and your name is?
Jim.
Jim. Okay, Jim, what you don't want to do is squeeze me together. What the research has shown is that just enough force as if tightening your shoelaces is enough to often to stabilize the pelvis. Perfect, perfect palpation. Okay, so that's what it should feel like. So my weight's going over my foot, I'm finding my foot, stacking my hip, and then lift my leg. All right? I'm way over to the lateral side there, that's better. Okay? Now, if I fire up my rec fem, TFL, psoas, adductor, longus, brevis, feel that? So it hasn't given way, but my pelvis is now anteriorly tilted.
Right there, just a little bit of.
But it hasn't happened in the pelvis, has it? My whole, that hasn't happened between the sacrum and the innominate. My whole pelvis is doing this, but more subtle. Yeah, so all I'm doing is focusing in on the front of my thigh, and I'm doing that. Now, if I at the same time, so keep your thumb on my sacrum, and you'll really feel this multifidus let go. If I let my multifidus let go, and now I stand on my leg.
This just drops.
It just, yeah, and just went forward.
Yeah.
So that dropped, this
sort
went
of
forward.
do that. Yeah.
Exactly. That gives way, and I feel that go right up into my back. So my back starts to hang on with that, okay? So that's a hip flexor, adductor, anterior muscles dominating the posterior muscles, in addition to my core letting go, okay? Now this would be a terrible thing to have on the video, because I would never, ever do this. Rick, watch this. If I let my belly go, isn't that gross? If I let my core go in the front, you can feel right away my pelvis goes into a posterior tilt.
Yeah.
Yeah? So I lost my TA pelvic floor support. So there's TA pelvic floor support. So I let my pelvic floor hang. And then I let my belly go.
Yeah.
And then right away I stand in an anterior pelvic sway. Okay? So now if you go down onto my hamstring, and watch what happens in that strategy. So you see these all the time. You see hockey players, they do this all the time. They do this. Stand like this. Drives me crazy. Okay. So now when I go into this position, I let my core go, let my floor hang, and do that.
Sort of you're firing there.
I'm firing, because I have to stabilize with something.
Yeah.
So now my leg is stabilizing like crazy. So you can see why with that one player, I think his number's number 12, he's back like this. And he's got his leg out like that. And he's really open in the hip. You see my hamstrings doing?
Yeah.
Now, if I merely correct my pelvic position, way less work in my hamstring, right? Way less work from being
there
to being there.
Yeah.
And all I've done is centered my femur. Now, if from this place I'm going to rotate. So I have a fourth thoracic ring shift that doesn't do what it's supposed to do at times. So if I stack that, and then get my thorax on top of my leg, there, now I'm there, now I'm there. Okay, versus being somewhere where I shouldn't be. Okay, now I ask, that's just to give you an example of the different things that you can feel. And the more you start to play with some of these things and feel the SI joint, the more you go, whoa, this is really giving life. Okay?
Yeah.
Right? Cool, so then you can teach you and Rick can teach you. That's not feel that one. Cool, have a seat. Let's some people go, oh, that movement is so subtle, and I can't possibly feel it, but you can. Close your eyes, slow down, feel your wives, your girlfriends, your kids, and people who have pain, and in no time you'll start picking it up, right? But be sure to use the palm of your hand, because it is the most sensitive thing. Yeah, and you'll start to feel it. Now, it isn't always obviously on the side where the muscle recruitment's changing. So we saw that some of you had failed load transfer on the left side of the pelvis, but it was dyssynergy in the right leg. Because the pelvis is a ring, it's a circle. And anything entering the circle in any part of it can affect the whole circle. So we have to stop thinking about the right and the left side of the pelvis. When something affects the right SI joint, the whole circle is impaired. And you may end up increasing activation of the left leg to compensate for the right leg. It's not divided in the middle. Okay? Make sense? It's a ring. It's a circle. All right. Well, what about this thorax? The thorax is like 10 stacked pelvises on top of each other, and 2 little incomplete stubby things sticking out the bottom, 11th and 12th ribs. All right. But essentially, we cannot separate the function of the ribs from the function of the spine. And so what is the role of the thorax when we stand on one leg? We don't know. It's not been measured. Most of the research that's been done has looked at the leg and the pelvis in the absence of the trunk, the third lever that's sitting on the top of it. So our hypothesis is that all the rings should move laterally over the weight-bearing limb with no loss of segmental control. So you don't want one pelvis going one way and one pelvis going the other, one ring going one way and one ring going the other in the thorax. They should move in harmony as a unit. Now, years ago, long time ago now, probably a decade ago, LJ was working with a number of her athletes, noticed that there are many people that had non-optimal control within the lumbopelvic region that was due to impaired neuromuscular patterning in the thorax. So they weren't able to control the rings in the thorax. And she started to, these are the days where we were doing a lot of training of transversus, trying to get transversus to work in isolation from other systems, and we just couldn't find the best cue to get either multifidus or transversus to work. And one of the things that LJ realized is that the abdominal wall, she didn't realize this, but the abdominal wall is innervated by nerves from the thoracic spine, from T6 to L2. So the lower 6 thoracic rings provide the nerve supply, and thus the motor information to the abdominal wall. So if anything is affecting this part of the thorax, so it could be something higher that's affecting those rings, but if these rings get affected and get shifted, it can change the neural drive to the abdominal wall. And by correcting and aligning and mucking around in the thorax, you could actually wake up the transversus down low and control the pelvis again. So this was her clinical experience, and at the time she was traveling and teaching with Paul Hodges, whom you know has done a lot of research in motor control and lumbopelvic region. And she started to express some of her ideas to him, and he suggested that she then follow them up, back them up with some data, and invited her to join him to do her PhD at the University of Queensland, which she has just submitted. So her PhD was on motor control of the thorax and its contribution to lumbopelvic trunk function, basically. And in one of the studies they looked at, and they had to their studies were done all on normals because there's no data in terms of what is the normal motor control of the thorax. And so unless we know that, we have no idea how to interpret those with either thoracic pain or with pain anywhere else. So she repeated the arm perturbation studies, those famous arm perturbation studies that Paul's done that's looked at motor control in and around the pelvis and in the low back. And the muscles that they looked at in particular were multifidus and longissimus. And longissimus is really the interesting one for me in that longissimus and iliocostalis actually are the links, the anatomical links connecting the thorax to the pelvis. All right, so the erector spine, the one that is connecting the two. And so in the normals, what she found is that both multifidus, the deep multifidus and rotatories and longissimus do function as extensors of the trunk. So if you need the extensors to stop you from falling over, they activate in a very similar way, but they function opposite in rotation. And it's just because of partly because of the orientation of the fibers. That one is a right rotator and the other is a left rotator, so they function differently. Okay? Now, we know from tons of evidence in in the literature that when you hurt your back, the erector spinae muscle tends to go into spasm. So you see tight back muscles. Well, where do these back muscles go? Yes, they do compress the lumbar spine, so a huge compression on the lumbar spine. But some of them attach to the iliac crest, iliocostalis in particular, and others attach to the fascia over the sacrum. So when this system becomes hypertonic, goes into spasm or becomes tight, and if you also have associated inhibition of the intercostals and of multifidus, what can happen is that it can create these buckles or these shifts or giving way within the thorax. Similarly, because of this pull in this vector, because it pulls up on the innominate, okay, so if it's going to pull up on the innominate at the back, it's going to have the same effect at the sacroiliac joint as the hip flexor scenario I took you through in the front. Okay, so heaven help you if you've got hypertonic tight hip flexors and a tight back. Poor SI joint doesn't have a hope in heck of staying stable, does it? Because you've got things from the front of the leg pulling down and things from the back that are pulling up. Okay? So this is the slide, this is a study from McIntosh and Bogduk, which shows specifically the attachments of iliocostalis and longissimus. And I only put it up there to show you that this little number here, this says T4. So iliocostalis from your fourth rib, way up here, fourth rib's at the nipple line, okay? Way up here, from the fourth rib, attaches all the way down to the PSIs. And how common is it to have someone come in and go, I've got this pain, and it's right here. Or even along this entire part of the ilium. So many people that get injections and corticosteroids injected into this part of the iliac crest. This becomes almost like a tennis elbow when this muscle, these muscles here, are hypertonic in terms of where they go. Okay? And you can actually, when you start to palpate the muscle, if you're doing massage or release techniques, or you're doing ART or whatever, you're just trying to get the guy's back to lengthen out, you'll actually start to feel what feels like a pepperoni stick in the middle of a salami, right? So you feel one fascicle, and if you trace that fascicle up of the muscle, you'll find that it goes right to the specific rib, which is part of the whole ring within the thorax, and is likely creating the problem up there. Okay? So if we come back and look at our triathlete again, and now I bring your attention to what she does in her thorax. When she stands on her right leg, she leaves her thorax behind. So she has asymmetry of movement when she lifts her right leg, and you can also feel and trace this fascicle all the way up. Actually, it goes higher than where I'm palpating. It goes all the way up to about here. So as this fascicle in her back is being dominated, so this is no different than what we felt with biceps and semi-mem, sort of an imbalance in her back muscles. And now what's happening is that it keeps pulling this rib down. But this doesn't happen. The rib doesn't just posteriorly rotate. The rib is part of the whole ring. So when it posteriorly rotates that rib, it torques the whole ring. Okay? When you posteriorly rotate a rib, it torques the whole ring. Okay, so you can see on the model how it's an integrated ring, and this is really LJ's big point about how we can't consider the thorax as just being connected bones. They are all interconnected, and it's important to look at them together. So there's a huge body of science that shows that motor control changes are variable in patients with pain. They don't all do the same thing. But specific to low back pain, we often find that there's reduced activity often in the deep muscle, not always, but most often. So it's been reported that there's reduced activity in transversus, delayed activity in transversus or deep fibers of multifidus. You felt in each other that there can be a delay in the activation of the glutes, glute max in particular. Steve Saunders has shown less tonic activity in transversus and gait, particularly at higher speeds in people with pain. Henry Salve has shown that there's a cortical reorganization, which is evidence to support that the brain is involved in this, the nervous system's involved in this, in terms there's a change in where the brain map is in transversus. I don't know how to use that information clinically other than that it supports rewiring, sequencing, and timing of muscle activation. Reduced spinal excitability, atrophy of multifidus, and fatty infiltration. So we're getting lots more information about what happens to our stabilizers in the presence of pain. But we also see augmented activity, most often in your superficial muscles. So the obliques, the oblique abdominals, and particularly in erector spinae. Now, the common link across all patients with pain is the strategy they're using for the task is not optimal. So if you're looking at one-legged standing, they are not able to balance and to control the multiple rings in the trunk in such a way that the pelvis lands on a centered femur head and the weight goes straight through the navicular and the cuboid, and they boom, find their foot, right? So the strategy becomes not optimal. And you have to assess the individual patient. It's not always the same. We can't predict what pain will do. We can't predict which impairments will cause pain, all right? And again, this is just a reminder from that slide. So here's an example of some things of what this looks like clinically. This fellow is actually an Olympic biathlete, believe it or not. And as he stands on his right leg, you can see that right SI joint is giving way. But he also tends to stand with a very anterior hip. So you see this divot in the back of the buttock, and my hand is already starting further forward. As he shifts his weight onto the right leg, you can see through my hand that his femur actually internally rotates, and then his SI joint gives way, all right? So, it's already starting forward. He shifts his weight, it internally rotates, and then he picks up his left leg, and then the anterior rotation of the innominate occurs. Now, I'm not feeling the sacrum. I've already noticed that when the innominate anteriorly rotates, it's not a tilt, it's a within the pelvis giving way. So as soon as I feel that innominate go forward, I know that it's about the SI joint. So the first thing to give way in this fellow is his hip, right? So the driver in just this one task would be, in terms of the area that has more importance, is going to be about his hip. So it doesn't really matter about what's going on within the pelvis. You've got to get that hip back. So we've got to figure out what it is that's pushing the hip forward, what it is that's creating that problem. Now this gal has pelvic girdle pain, but look at her foot. She has an old ankle injury. She sits with her talus and her navicular on the floor. She doesn't support her arch very well at all. And that pronation of her foot, or drop of her foot, actually creates a very big internal rotation spiral, because the talus is a mortise joint, and so it belongs to a mortise joint. And so as it plantar flex and adducts, it will create an internal rotation force up the leg. Now, she also has an unlocking SI joint, or a giving way SI joint. So she stands on her left leg, and there it is. So it's hard to see, right? It's much easier to feel than it is to see. So this is giving way. Her foot stays collapsed. And when I give her a cue to stack her talus, so imagine a guy wire coming up from the inside of your foot and just support the talus up on top of your heel bone. Now shift your weight. It's difficult for her to manage because it's a new map for her brain, and her balance is way off because her virtual body doesn't understand it. But look at her SI joint. It doesn't give way. So even though her pain is in her pelvis, the place to intervene and to start with this gal is with her foot. All right? What do we have to do to correct the sling in her foot? Get her perineals and her tip post working better, get all the muscles in her foot working better, do some vector taping, perhaps put her in a temporary orthotic, get her foot working a whole lot better. Then her pelvic girdle. Then we can start to address her pelvic girdle. This is a pelvic-driven foot. Okay? Now, this is a thoracic-driven pelvis. So here we have an unlocking SI joint on the right side. This woman's just had twins. She's about 3 months postpartum, having twins. Principles are the same. So a giving way SI joint, and LJ's monitoring the fourth ring up here. And her fourth ring is shifting. Okay? So she's on her left and right fourth ribs, and as she shifts her weight to the right, she's feeling this ring shift to the left. I'm feeling the SI joint give way. Okay? So then, is this a thoracic-driven pelvis or a pelvic-driven thorax? So then LJ will correct, so she'll come in and she'll take that ring, a little bit of traction, stack it up, line it up, hold it in place, and then the person stands on her leg, and lo and behold, there's no unlocking. So this is a thorax-driven pelvis. And in a postpartum woman who's had twins, most therapists would go, oh, you need to get your abdominal wall strong. Again, you need to start training it. It's not where we begin with this gal. It's not where we begin to intervene. Okay? So the one-legged standing task, you're gonna read about it through the literature. If you're reading the literature, it's being used more and more because it's a valid test. It's shown inter-tester reliability. The sensitivity and specificity studies haven't been done yet. However, in our opinion, when you have failed load transfer, when it gives way, it doesn't mean the pelvic